name is Paul Riley from the scientific marketing team at Diagnostic Astago, and I wish to present one of our Lab Week speakers, Dr. Anna Merrill. She is a board-certified clinical chemist with expertise in toxicology and coagulation. She is currently a clinical associate professor of pathology and associate director of clinical chemistry at the University of Iowa Hospitals and Clinics. She is heavily involved with assay development and validation using both automated and specialized methodologies, such as mass spectrometry. Her research interests including data-driven quality improvement initiatives in all phases of the total testing process in the laboratory. Dr. Merrill, welcome today, and thank you for agreeing to speak for us today, and please take it away.
All right, thank you, Paul, for that kind introduction, and thanks to Stago for the opportunity to present today, and I'd like to wish everybody a happy Lab Week. The title of my webinar is Direct Oral Anticoagulants, or DOACs, Measurands and Interferents in the Clinical Hemostasis Lab. Here are some of my disclosures. And then today I have three primary learning objectives. First, I would like us to be able to compare and contrast the mechanisms of action for DOACs, especially relative to other common anticoagulants like warfarin and heparin. I would like us to explain the impact of DOACs on routine coagulation tests, and then finally evaluate the utility of laboratory testing for DOACs, especially in emergency settings. Now to get there, we'll first spend a little bit of time talking about DOACs, so what they are, why they are prescribed, and how they work. And then the bulk of our time together we'll spend talking about different challenges DOACs pose for the clinical lab. And this will be split into two parts. The first part we'll talk about how DOACs interfere. And then in the second part, we'll talk about how labs may choose to measure DOACs in different situations. So let's get started. So the direct oral anticoagulants, or DOACs, really comprise two main groups of anticoagulants. So there are the direct thrombin inhibitors, and dabigatran or Pradaxa is an example of a direct thrombin inhibitor. And then there are the direct factor Xa inhibitors, rivaroxaban, apixaban, and edoxaban. And here I've shown a couple of structures of these small molecules here on the right, so dabigatran on the top and apixaban on the bottom. And these are really, these classes of anticoagulants are really growing rapidly in clinical use, as we'll see in a couple of slides. But how do they work? And so no coagulation talk is complete without the obligatory coagulation cascade image. So here that is on our right. So we're first going to talk a little bit about warfarin and heparin and how these anticoagulants work so that we can make sure we can understand how the direct oral anticoagulants differ. So warfarin works by reducing plasma concentrations of active vitamin K dependent proteins. So procoagulant factors 2, 7, 9, and 10 are vitamin K dependent. And then anticoagulants protein C and S are also vitamin K dependent. And so warfarin therapy is monitored and adjusted by the PT-INR, as we all know. Now, unfractionated heparin, these are indirect inhibitors. They accelerate the action of antithrombin against activated factor 10 and against thrombin. And unfractionated heparin therapy can be monitored in a couple of different ways. You can use the partial thromboplastin time, or you can use a chromogenic anti-10A assay. Now, getting to the DOAC, so there are direct thrombin inhibitors, and these small molecules directly inhibit factor 2A or thrombin in both the free and the clot-bound form. They will also inhibit platelet aggregation, so primary hemostasis that is induced by thrombin. And finally, the most popular class of oral anticoagulants are the factor 10A inhibitors. And these, like direct thrombin inhibitors, will bind directly to activated factor 10 in the clot-bound form, and also factor 10A within the prothrombinase complex. And so that is how the factor 10A inhibitors work. And so these two classes of direct acting or anticoagulants are very different than the indirect inhibitors, warfarin and heparin. And here's a timeline showing the FDA approval in the United States of these different direct oral anticoagulants. And so dabigatran was first back in 2010. Rivaroxaban and apixaban soon followed. So these were the direct 10A inhibitors in 2011 and 2012. Edoxaban is the third 10A inhibitor that has been approved in 2015. And then most recently in 2021, dabigatran and rivaroxaban were approved for pediatric use. So in adults, why would certain, adults be prescribed these oral anticoagulants? So there are a couple of main patient populations that it's very common to see these, medications. So first, if you're a patient with non-valvular atrial fibrillation, this is a first-line therapy. These direct oral anticoagulants are in order to prevent stroke and systemic embolism. And so actually, it's been quite a while, over 10 years, since these direct oral anticoagulants actually became more common than warfarin for this specific clinical indication. Now, other patients that are prescribed DOACs in the outpatient setting would be those that are needing VTE treatment and to try to reduce the risk of recurrent VTE. And also in patients getting joint replacement surgeries, they are at higher risk for thrombosis, and so they will be prophylaxed with a DOAC. In pediatric patients, these medications are used to treat and to prevent recurrence of VTE, and also for VTE prophylaxis in a specific procedure. Also worth noting is that there are now antidotes available for DOAC reversal. And so there are 2 of these that are available. These were not actually available at the time that the medications were approved by the FDA. The first one of these reversal agents is Praxbind, and this received accelerated approval in 2015 and full approval in 2018 for dabigatran reversal. And then Andexanet alpha, or Andexa, was granted full approval in 2018 for both apixaban and rivaroxaban reversal. And so we'll come back to talk about antidotes in the second half of the webinar. So these, I think part of the reason these oral anticoagulants have become so popular is that in clinical trials, they have been demonstrated to be non-inferior to the standard of care, which typically has been warfarin, meaning that they do a similar job of preventing stroke and preventing thrombosis, but they are safer for our patients as they have fewer episodes of major bleeding. And so that's really one of the main reasons that has propelled the popularity of these anticoagulants. And also another bonus for patients is that unlike warfarin, these medications do not require routine monitoring to adjust the dosing. So let's take a look at how the use or the number of prescriptions on the y-axis has changed over the last decade or so. You can see that back in 2013, now this is oral anticoagulants for all indications, but warfarin was certainly the most common back in 2013. And you can see the decline in the proportion of warfarin prescriptions that corresponds with the increase in initially rivaroxaban, and of course that was approved earlier, and then now apixaban comprises about almost 50% of the oral anticoagulant prescriptions in the United States. Okay, now we will move on to talking about direct oral anticoagulants and how they might interfere with common coagulation testing. And I think it's important to note that when these medications were approved for patient use, they were approved without requiring, routine monitoring by laboratory testing, which was a huge benefit for patients relative to warfarin. But I think because of that, some providers might assume that because these medications don't need routine monitoring, that they might not interact or interfere with any of our coagulation testing that might be performed for other reasons. And that is not true. And so that's what we'll talk about next. Okay, and I want to start this section with one case. And so in this case, a thrombophilia workup was requested for a young female who had a history of multiple pregnancy losses and a DVT. And then in addition to her personal history, she also has a strong family history of blood clots. And so this patient, but prior to performing this or requesting this testing, had already been started on rivaroxaban. And here were the tests that were ordered for this patient, and here are the results. And so antithrombin activity, protein S and C activity, genetic testing for factor V Leiden and prothrombin gene mutations, lupus anticoagulant and anticardiolipin and anti-beta 2 glycoprotein 1 testing. So of note, These results are all within the reference range. None of the mutations were detected, but we do have detection of lupus anticoagulant, cardiolipin IgG antibodies, and beta-2 glycoprotein 1 IgG antibodies. So the question that comes to me, or that might come to you in your laboratory, is, can I trust these results? Does this patient have an inherited or acquired thrombophilia that might be the reason for her recurrent pregnancy losses? Okay, so the answer to this question depends on a couple of different things. So first, it depends on which anticoagulant the patient is receiving at the time of testing. And then it also depends on what type of assay methodology we are using in these tests. And so within coagulation or within coagulation testing, we actually use a wide variety of different assay methodologies. And it's really important to be knowledgeable about what types of testing is performed in your laboratory. And so I like to group these into 4 main groups. So we have clot-based assays. And so these are, are what we think of as our kind of routine tests: the PT, the PTT, thrombin time, fibrinogen, clotting factors, protein CNS activity may be assessed via clotting, and then lupus anticoagulant testing. So the endpoint in all of these assays is we measure the time it takes for our sample to clot given a certain stimuli. And so that is those are clot-based assays. The second type of testing are chromogenic assays. And so these are usually, again, activity-based assays, but the output does not rely on clot formation. It relies on generation of a color whose intensity we can measure using a spectrophotometer embedded within our coagulometers. And so, so chromogenic assays are used for antithrombin activity. Certain clotting factors have chromogenic counterparts. So for example, there's a chromogenic factor 8 assay available and also a chromogenic factor 10 assay available. There's also a chromogenic protein C activity assay available, and in addition to an anti-10A based assay that relies on chromogenic principles. The third type of assay methodology that we may encounter are immunoassays. So these are where we use antibodies to detect an antigen of interest. And so a very common coag test that uses an immunoassay principle is the D-dimer, for example. We use antibodies to recognize D-dimer. We also use similar methodologies for antigen-based testing, so protein S antigen, either total antigen or free antigen. And then we look for these antibodies, so anti-beta-2 glycoprotein 1 and anti-cardiolipin via immunoassay technology as well. Now, molecular assays using PCR, for example, are useful for detecting certain mutations. So factor V Leiden or the specific prothrombin mutation. So in general, immunoassays and molecular methodologies are unaffected by any anticoagulants. And so those are generally safe to perform in the presence of DOAC therapy. Clot-based assays are typically the most susceptible to interference, so not always. There are some caveats, but generally the clot-based assays are what we worry about the most. So a DOAC could prolong clotting more than it should. And then chromogenic assays, it really just depends, which is not sometimes the assay that our providers want to hear, but it's up to us as laboratorians to make sure we understand which assays are in use in our lab and how to advise our clinicians on which testing to order or how to interpret it. So we'll go into some details now of specific assays and the impact of dabigatran, apixaban, and rivaroxaban on these different tests. And I would like to start by saying that the next couple of slides have a few tables showing different assays and then the effects of different anticoagulants. And these tables have been adapted from a wonderful Cap Today article a few years ago by Dr. Adcock. And so I highly encourage you to take a look at that if you would like more information. So again, remembering what we just talked about, that whether or not a DOAC will be interfering with the routine coagulation testing that you are performing really depends on both the anticoagulant and the type of assay. And so you can see here the most common assays, the PT and the PTT, can be prolonged by dabigatran, which is the direct thrombin inhibitor. Now, they're also prolonged by rivaroxaban. Rivaroxaban tends to prolong the PT more than the PTT, though there can be reagent differences. So it really just depends on which specific PT and PTT reagent you use in your lab. Interestingly, though apixaban is also an inhibitor of factor 10A, it really does not have as much of an effect on the PT or the PTT. And so it might prolong it, it might not. It just kind of depends on how much of the medication is present, and it depends on your specific reagent. Now, the thrombin time is very sensitive to any inhibitors of thrombin. So that could be unfractionated heparin. It could also be dabigatran. It is extremely sensitive to dabigatran, but it is not affected by apixaban or rivaroxaban or any of the direct 10A inhibitors. Fibrinogen is mostly not affected by any of the DOACs. Unless you have a ton of dabigatran around, it will not affect fibrinogen. D-dimer is measured by immunoassay, so this is unaffected by any of the anticoagulants. And then chromogenic anti-10A assays that are usually in labs to measure heparin therapy are not affected by dabigatran, but they are affected by apixaban and rivaroxaban, because these are also anticoagulants like heparin that have activity against factor 10A. Moving on to factor testing, I have found that this the interference of DOACs on factor testing is not, I don't encounter this problem as often, because typically factor assays most often are ordered in patients where there is a concern for bleeding, and I have not seen that there is as much overlap with orders or requests for this testing for patients who are already anticoagulated. But there is the potential for samples with DOACs present to have interference with factor assays. And it really goes back to the fact that clot-based factor testing is really just based on the PT and the PTT, depending on which factor you're looking at. And so again, because dabigatran can prolong the PT and the PTT, it can actually make factors that are measured using those reagents appear lower than they should. And similarly, rivaroxaban and then apixaban can also do this if you're using a sensitive reagent. Now, when we do factor measurement with a clot-based assay, we do multiple dilutions with our patient sample into factor deficient plasma. And so that the higher fold dilutions can actually help dilute out the inhibitor effect. But some studies have shown that that the effect sometimes persists even at the highest kind of typical dilutions that labs would do. I mentioned earlier that a few factors have chromogenic assays available. So factors 8 and 10 are two examples of this. And both of these actually rely at the very end of the assay on factor 10A activity. And so because of this, they're really not affected by dabigatran, but they will be falsely low in the presence of apixaban or rivaroxaban. Now, finally, I think where it's really important to understand the impact of DOACs is when you have thrombophilia testing that has been requested. And this is usually where we see the most intersection of testing being ordered on patients that are also already on DOACs, because these patients have likely already had a VTE and now are being treated, and the provider might be trying to figure out the source of the thrombosis. And so why don't we start with looking at antithrombin activity? So this is measured by chromogenic principles that either rely on factor 10A or 2A activity at the end to generate that chromogenic signal that we then detect and correlate with antithrombin activity. So it's important to understand if you run antithrombin activity testing in your lab, it's important to understand which version of the assay you are running. Because if your lab utilizes a 10A-based assay, as my lab does, dabigatran will not affect this assay, but apixaban and rivaroxaban will falsely elevate it. So in a patient that might have an inherited antithrombin deficiency, the presence of the apixaban or rivaroxaban could actually falsely elevate the antithrombin activity such that it is not within the reference interval. So you could miss the diagnosis of antithrombin deficiency. Now, if your lab uses a 2A-based assay for antithrombin, then the opposite would be true. Dabigatran would affect the assay, but apixaban and rivaroxaban would not. Now, moving down to protein C and S testing, this can either be done by clot-based mechanisms, chromogenic, or antigen or immunoassay-based methods. So if you measure protein C or S activity by clot-based mechanisms, this could be falsely elevated by any of these direct oral anticoagulants. Meaning, just like with our concern with antithrombin activity, is you would potentially be elevating a truly low result and potentially missing the diagnosis of a deficiency. If you measure protein C activity via chromogenic principle, this is not affected by any of the DOACs, nor is doing antigen-based protein S testing. And so those would be the assays that we would recommend if that is possible for your laboratory. Testing for mutations is not affected by these DOACs, and neither is testing for anticardiolipin or anti-beta-2 glycoprotein 1 antibodies. So those results should be reliably, they should be able to be reliably interpreted even in the presence of DOACs. Now, finally, lupus anticoagulant testing can be, is because this is clot-based, this is prone to interferences from DOACs. And while we mostly worry about potential false positive lupus anticoagulants in the presence of any of these DOACs, meaning the patient doesn't actually have a lupus anticoagulant, but the medication makes it seem like they do, it's also been demonstrated that apixaban can also lead to false negative lupus anticoagulants, meaning you have a patient that actually has a lupus anticoagulant, but the presence of apixaban makes that lupus anticoagulant behave differently in your assay so that you actually miss the diagnosis, which is considerably more concerning than a false positive, though I think it is a more rare situation. Also worth noting, as I mentioned with the asterisks, is that for lupus anticoagulant testing, even at very low concentrations of these medications, DOACs may still interfere. And so there's not really a safe threshold that has been determined that if your DOAC is above or below this threshold, you are no longer susceptible to interference with lupus anticoagulant testing. And just a little bit further on the importance of understanding the potential interference of DOACs on lupus anticoagulant testing specifically, because this is very, very clinically important and will potentially very strongly influence clinical management, where it might not necessarily with some of these other thrombophilia tests that we just mentioned. So it's important to realize that currently DOACs are not a recommended anticoagulant for patients with high-risk antiphospholipid syndrome. And so there has been a recent study that compared, it was a randomized control trial that compared rivaroxaban with warfarin in patients with high-risk APS. So that means they have lupus anticoagulant, and then they have anti-cardiolipin antibodies and anti-beta-2 glycoprotein 1 antibodies at the same isotype. These patients were randomized to either receive rivaroxaban or warfarin, and they were monitored for follow-up. And actually, this study was stopped early because the rivaroxaban group performed so poorly. So there were 19% of patients in the rivaroxaban group had events. 7 were thromboembolic, and 4 had major bleeding events. Whereas only 3% of patients that were randomized to warfarin had events, and they were all major bleeding events. There were no thromboembolic events. And so patients who fall into this group should be changed to warfarin therapy. And there are even some guidelines are conflicting in terms of if it's just high-risk APS patients that need to be on warfarin versus a DOAC, or if any APS patient should really be on warfarin versus a DOAC. Okay, coming back to our case. So this was our case of a young woman who's had multiple pregnancy losses and DVT with a strong family history of blood clots. So we have all this testing that has been performed, and the question comes to you, does this patient have an inherited or acquired thrombophilia? So it's important to note that since this patient has already been started on rivaroxaban has the potential to interfere with many, but not all of these tests. So first, let's maybe start with the tests that we know are safe for our patient. So if we have any tests that are performed with molecular assays or immunoassay methodologies, those should be reliable. So shown here with the green dot, factor V Leiden mutation, prothrombin gene mutation are reliable. The detection of IgG antibodies to cardiolipin and beta-2 glycoprotein 1 are also reliable. Now we deal with clot-based and chromogenic tests. Now these have the potential to be falsely elevated. And so to start, clot-based tests are usually where we're the most concerned. And so in this case, lupus anticoagulant testing was performed using clot-based assays, and protein S activity was also performed. So protein S activity, it was reported within the reference interval, but this could have been falsely elevated by the presence of rivaroxaban. And this lupus anticoagulant may have also been falsely positive due to the presence of rivaroxaban. The other assays relying on either chromogenic or clot-based principles kind of depend. That's why they're shown in yellow here. So for antithrombin activity, whether or not the result is reliable in the presence of rivaroxaban depends on the exact chromogenic methodology of the assay. And in our lab, we use a chromogenic 10A-based assay, which would be affected by rivaroxaban. But not all labs might. Other labs might use a different methodology. So it's important to know that. And in our lab, we measure functional protein S activity via chromogenic principles. This one's actually okay. but they're shown in yellow here to remind us that we really need to know the specifics of our laboratory's assays. What approach might work for one laboratory might not work for another laboratory, depending on the testing being performed. Okay, the second case for this section is a 57-year-old male on rivaroxaban and carvedilol. He's admitted to the hospital with concern for septic shock and acute kidney injury following a recent admission for ischemic bowel. And so his last dose of rivaroxaban was about 24 hours prior to this presentation. Because this patient had a recent history of DVT and PE, they started him on unfractionated heparin. So the question now is, which coagulation assay should be used for unfractionated heparin monitoring in this patient? Okay, so there are multiple options for monitoring unfractionated heparin therapy, but in recent years, chromogenic anti-10A assays are actually recommended in most instances over PTT-based monitoring. They've shown that using this monitoring strategy, patients get to the therapeutic range sooner, they stay there longer, and they have better outcomes. They need to be monitored actually less because it is more stable. And as here is an example of how this chromogenic anti-10A assay works. So the reagent supplements an excess of factor 10A, which is bound by antithrombin and heparin in the patient sample, proportionally to how much heparin is present in the sample. So if no heparin is present, none of the excess factor 10A in the reagent is bound. If a lot of heparin is present, then a lot of this is bound. Any residual or free factor 10A after this first step interacts or acts upon a chromogenic substrate to produce a color that we measure at 405 nanometers wavelength, and that will then, the signal of that will then be inversely proportional to how much anti-10A activity is in the sample. So the problem with this is that this chromogenic anti-10A assay is not specific for heparin. So anything that has, any compound that has anti-factor 10A activity can interact with this part of the reagent and prevent factor 10A from converting substrate to chromogenic product. So it can be a problem when transitioning a patient on DOAC therapy to unfractionated heparin for anticoagulation. So what to do if you're in this situation? You have a couple of options. You can use a DOAC insensitive PTT reagent. So this again depends on the reagent, and you would still need to maintain the PTT-based heparin nomograms for adjusting unfractionated heparin dosing based on the PTT. You could, some laboratories have implemented something called a corrected heparin assay, which is shown here on the right. So in this setup, you would actually perform a couple of different steps in order to get a corrected heparin value. So you would run your chromogenic anti-10A, knowing that would be reflecting activity from both your DOAC and your heparin. You then remove heparin from the sample and remeasure the anti-10A assay, and then subtract this value from this value to get the corrected heparin. That is one strategy. Otherwise, you could use DOAC neutralization. And there are a few different approaches that are available for DOAC neutralization. I'm showing them here on the screen. So on the left, there are DOAC neutralizing tablets that have activated carbon in them that when you incubate these tablets with your patient sample, they will absorb the DOAC. And so these products, a couple of examples are called DOAC Stop or DOAC Remove. The other option is to use a neutralizing filter. So these filters rely on non-covalent binding through the solid phase. So you start with your sample, up here, and then you will centrifuge the sample, and what comes through the filter should be DOAC free. And so these are a couple of options that are available to labs that have decided that DOAC removal or neutralization strategies are needed. I will note that none of these have been approved for use from the FDA, and so laboratories would need to validate the use of these products to make sure that that the performance of their assays is still suitable after using this product. There have been lots of examples in the literature. I won't probably go into too much detail about how effective these products are at removing DOAC activity from samples. So here's just one example showing for samples containing a good amount of apixaban or rivaroxaban, what treatment with the DOAC Stop product will do. So before and after treatment, shown here on the right. Similar performance was demonstrated for the dabigatran and argatroban sample, so direct thrombin inhibitor samples with the same product. You don't need a different product for the different types of DOACs. And the use of this product in this study generally reduced the amount of DOAC interference with lupus anticoagulant testing based on a variety of different methodologies. So PTT, silica clotting time, and DRVVT based testing. DOAC remove is another example that also has worked well to neutralize concentrations of DOACs. And then this study showed more examples of what the impact of increasing amounts of spiked DOAC in the sample did to the DRVVT ratio, and then how the DOAC remove or DOAC R product did to correct that. So in panel A here, this is spiked donor plasma, and panel B, this was spiked controls, like a positive and a strong positive and a weak positive lupus anticoagulant control. And then in panel C, showing the impact on spiked samples that already had either a pretty strong positive or a fairly weak positive lupus anticoagulant. So back to our case number 2. This was a patient who was on rivaroxaban on the outpatient side, but now is admitted and needs to be on unfractionated heparin. So what can we do to monitor his unfractionated heparin in this setting? So prior to starting unfractionated heparin, our team or the providers actually ordered a PTT and a heparin anti-10A and a rivaroxaban value. And so our rivaroxaban was around 43 nanograms per ml, which corresponded to a baseline value of 0.3 units per ml of heparin in our heparin calibrated anti-10A assay. So they actually decided to use the PTT-based nomogram for unfractionated heparin monitoring, because our PTT assay at my institution is not very sensitive to rivaroxaban and apixaban. So my recommendations for dealing with DOAC interference to close out this section is to provide educational materials to physicians and other healthcare providers. This is kind of a constant battle. You need to have multiple modes of education. It needs to be ongoing, because especially if you're at a teaching hospital, there will be rotation of your medical students and residents, and you can never have too much education. There are other things you need to do as well, though. You need to take a look at your test menu and see if there are any alternatives to tests that you perform that are less affected by DOACs that still offer good performance for what the test is needed for. So in my case, one example would be we used to perform clot-based protein S functional activity testing. And within the last couple of years, we switched to the free protein S antigen as our frontline test for protein S deficiency screening. If you have somebody who was on a DOAC that needs this testing, it's important to appropriately time the blood draw relative to DOAC administration. So things to consider are, can the patient be off of their DOAC for a couple of days, 2 to 3 days, to let the DOAC clear, and then we can collect the blood to do the necessary testing. If that can't happen, could they be transitioned temporarily to low molecular weight heparin? And if neither one of those are possible, that really is a decision that's up to the clinical team, because they know they can better balance the risks and the rewards of temporarily halting the DOAC. If neither one of those is possible, then you could always draw the blood at what would be a trough draw right before the next DOAC, before taking the next dose. It's important to develop testing algorithms to detect DOACs in submitted samples. This might not be important for every type of test, but one area in my lab that we've done this and it's been really useful is in our lupus anticoagulant testing. So for every sample that's submitted for lupus anticoagulant testing at my facility, we always run both a thrombin and we run a chromogenic anti-10A activity. And with those two results together, we can figure out if the patient is on any of these anticoagulants, and that helps us formulate our interpretation and potential limitations of testing. And then finally, if your lab, this is a lab specific decision, but you might want to consider DOAC neutralization in plasma samples prior to testing. Okay, now we'll move on to the second part where we talk about DOACs as not interference, but as measurands. And so you might remember at the beginning of this presentation, we talked about how one huge benefit of these medications is that unlike warfarin, they do not require routine blood monitoring or testing. So you might be wondering why we're even talking about this. And so I'll start again with a few cases to kind of set the scene. So in this case, we have a 75-year-old woman. She has a history of DVT, presents to the ED with headache, nausea, and changes in her vision. So she has some imaging done, and that's concerning for an intracranial hematoma. And if that would require kind of emergent surgical intervention. She is currently prescribed rivaroxaban, but she is a poor historian and can't remember exactly when she took her last dose. So the question, the initial laboratory studies are shown here. So we have a slight prolongation of the PTT, but everything else is otherwise normal or within the reference interval. And the question is, and this is usually what the neurosurgeons might want to know, is this patient currently anticoagulated and can she safely proceed to surgery? Case number 4, the next case, this is a little bit of a different scenario. Here's a 52-year-old male, history of DVT, who has had recurrence despite treatment with kind of standard apixaban therapy for 5 years. He does have multiple comorbidities, including type 2 diabetes and chronic kidney disease. And the patient's hematologist is concerned that the patient might not be taking the apixaban as prescribed. So again, some kind of initial coagulation lab studies are essentially normal. And the question from the hematologist is the patient adhering to his apixaban therapy? Now, before we go any further, I want to spend just a second talking about therapeutic drug monitoring, or TDM, and specifically about situations where TDM works well and is actually clinically necessary for patient management. So this usually occurs when the medication has a very narrow therapeutic index, meaning there's not very much room between how much of the drug is effective and then how much of the drug would be toxic. And so that's when it really can be helpful to monitor the drug concentration and adjust dosing correspondingly. It also helps in situations where we cannot reliably predict the concentration in the blood of a drug given a certain dose. There is unpredictable pharmacokinetics, and so we need kind of the functional readout of the drug concentration in the blood. There also needs to be a good relationship between basically with what to do with that blood concentration once we get it. And then there need to be serious consequences for under or overdosing of the medication. And then finally, we need the result to be interpretable and actionable. And so a great example of this is actually warfarin. So we know that we have a well-established kind of standard therapeutic range using the International Normalized Ratio, or INR, of 2 to 3. This is necessary because warfarin has variable pharmacokinetics. And we know that if patients have a subtherapeutic INR, that they're more at risk of thromboembolic events. And if they have a supratherapeutic INR, that they are at risk for bleeding events. And so we use that to adjust dosing of warfarin. And monitoring warfarin in this way has really improved the quality of therapy and clinical outcomes for patients who are receiving warfarin therapy. So, do DOACs meet any of these criteria that would necessitate effective and necessary therapeutic drug monitoring? So they don't really, and actually that's the main reason why most guidelines suggest against measurement and monitoring. So why are we even talking about this? So one of the reasons is that we now have available some reversal agents that are available for use in patients who come in with life-threatening bleeds or who might require urgent invasive procedures and who are on these direct oral anticoagulants. So again, these reversal agents have only been available for patient use for the past, like 5 to 7 years or so. So they're still relatively new. But one example is andexanet alpha, and this is the reversal agent for the rivaroxaban and apixaban. So just to give you an idea, it's tens of thousands of dollars for the low and the high dose therapy, and this is dependent on how long ago the patient's last dose was. And then not only from a financial consideration, but also from a patient safety perspective, the Anexa-4 trial was a clinical trial that led to the approval of this reversal agent, and thrombotic events were observed in 10% of patients on this trial. And so having a tool to guide a use of this therapy can be helpful. And then sometimes you have patients who are on a, supposedly therapeutic dose and they still develop clots. And so there might be a question about therapeutic compliance. There might be a concern about impaired metabolism from renal or hepatic insufficiency. And then finally, which might be sometimes my favorite, is curiosity. And sometimes I think we all like having numbers, and we think that magically once we have a number, we will know what to do with it. And so these might be reasons why you might be asked to measure or have assays available for measuring DOACs within your laboratory. I will say at this point, though, that measurement and monitoring are not the same thing. Monitoring implies that you have a measurement and then you will adjust the dosing based on that measurement, which is not what we will be talking about. We will be talking about having assays available for measurement to kind of guide these different clinical actions. Okay, so starting a little bit with direct thrombin inhibitors, which are not as commonly prescribed as the direct 10A inhibitors. So assays that are suitable for measuring direct thrombin inhibitors, the thrombin time is actually very sensitive to the presence of DTI. So if you have a patient where you're concerned about whether they are on dabigatran or not, if they have a normal thrombin time, that essentially rules out the presence of a direct thrombin inhibitor. The PTT will prolong with increasing direct thrombin inhibitor concentration, but the effectiveness is actually variable between different PTT reagents. So the most accurate ways of quantifying direct thrombin inhibitors are all laboratory developed tests, or LDTs. There's a modification to the thrombin time called the dilute thrombin time that is more quantitative than the normal thrombin time. There are Ecurin-based both clotting and chromogenic assays, and then there, of course, is use of mass spectrometry. These are all more accurate, but harder for most laboratories to access. So here is a figure from a paper published quite a while ago now, showing the relationship between 3 different clot-based assays: the PTT, the thrombin time, and then this DTI stands for dilute thrombin time. And it's showing that the thrombin time is too sensitive. It basically is maxed out, even with just a little bit of dabigatran present. The PTT does increase, but it's not a linear or a very steep curve. And then finally, the dilute thrombin time provides the best performance for dabigatran specifically. Now, what about the more common factor Xa inhibitors? So the PT and the PTT reagents are actually quite variably sensitive to direct Xa inhibitors. And so they cannot really be relied on to rule in or out the presence of direct Xa inhibitors. And this is very disappointing for providers because these are reagents that are really accessible in most laboratories, and we can put out results really quickly. So the fact that we should not be using them to infer anything about the direct Xa inhibitors is disappointing. But here, this is a wonderful paper published a couple of years ago that evaluated the sensitivity of a bunch of different PT and PTT reagents to these to the 3 direct Xa inhibitors: rivaroxaban, edoxaban, and apixaban. And you can see here, I'm just showing a couple of examples that rivaroxaban and edoxaban, so the red and the green, there's an increase in the clotting time, kind of proportional with increasing amounts of drug that are spiked in. So that would be illustrating that these reagents are somewhat sensitive to these medications. But apixaban, shown in blue, is a flat line, meaning that you could have a lot of apixaban in a sample and your PT and your PTT would be, normal. Or you could have an abnormal PT and a PTT and it wouldn't be due to the presence of these oral anticoagulants. So important to remember that PT and PTT are not global assays of anticoagulation. You can have significant concentrations of direct Xa inhibitors in your samples and have normal PT and PTT results. And just to show you that, we collated, we do offer apixaban or rivaroxaban anti-10A testing here in my laboratory, and we'll talk about that in a second. And often those samples will also have a PT and a PTT performed on the same specimen. So I pulled for both apixaban and rivaroxaban containing samples shown in red and orange here. I pulled the PT and the PTT when available as a function of the apixaban or rivaroxaban concentration measured by anti-10A. And you can see there's absolutely no correlation. So this corroborates the previous slide in that you really cannot be using the PT or the PTT to know anything about the presence or the quantity of apixaban or rivaroxaban in your sample. So what can laboratories do? So there are limited options of FDA-approved assays available at the moment for quantifying direct Xa inhibitor concentrations. So for most laboratories, you will be doing a laboratory-developed test. And it's important to understand the use of the test or the intended use of the test so that you can make sure that the test that you design is going to be able to meet those clinical needs. And so for us, when we were initially having conversations with our emergency medicine pharmacists, who were the ones that brought this request to us, they said that we need these results we would like these results in order to guide reversal decisions. And in order to do that, we need results within a couple of hours. And so for us, the quickest way of getting a apixaban or rivaroxaban result to our providers was to use our existing heparin and enoxaparin anti-10A reagent, but calibrate it against rivaroxaban and apixaban. So since this reagent is already in use in our laboratory, it really should facilitate rapid turnaround time. And again, just showing the schematic of how the chromogenic anti-10A activity assay works. It's not just specific for heparin. It also will reflect, the presence of rivaroxaban or apixaban if they were there. So how did we approach this validation of a laboratory developed test for rivaroxaban and apixaban? So again, same reagent as we use for our heparin and enoxaparin assay, just calibrated with rivaroxaban or apixaban calibrators. But we evaluated precision both within run and between run. Accuracy, we looked at the recovery of calibrators made by a different vendor that had values that were assigned by liquid chromatography tandem mass spectrometry. We did method comparison with a validated assay. We did dilutions of a high sample to establish reportable range. One really important study was evaluating the limit of detection and quantitation to know how sensitive analytically our assay was. Then we also evaluated interferences, both from endogenous substances and also from other anticoagulants. And finally, we had to deal with how the results were going to be interpreted. And so I won't go into all the details. The assay was actually quite precise. The accuracy was pretty good as well. Our reportable range goes from 20 to about 500 for both apixaban or rivaroxaban. Our limit of quantitation was approximately 12 nanograms per mil for apixaban and 8 for rivaroxaban. Because this is a chromogenic assay, we evaluated interference from hemolysis, icterus, and lipemia. And then we also evaluated the presence of other anticoagulants, which I would like to talk about just briefly. And so we wanted to make sure we understood and had data to support how other anticoagulants might affect measurement of this assay. And so as expected, warfarin and dabigatran basically have no effect. But as expected, based on our knowledge of how the assay works, is that any other anticoagulant with anti-factor Xa activity will essentially be reflected in our apixaban or rivaroxaban assays. So what that means is if we have samples that actually have no apixaban or rivaroxaban present because we spiked them ourselves, but they have amounts of unfractionated heparin or enoxaparin, these will show up as apixaban or rivaroxaban in our assays if that is ordered. And likewise, if somebody is if the provider thinks somebody is taking rivaroxaban, but they're actually taking apixaban, we will not be able to differentiate between those two medications. And again, that all goes back to the lack of specificity in the chromogenic anti-10A assay and the fact that it reflects any anti-10A activity in the sample, whether it's via heparin or whether it's via apixaban or rivaroxaban. So that, I would say, has been a challenge. This has been a challenge to communicate with providers. Another challenge that has been hard to communicate with providers is the fact that we really don't have any therapeutic range that have been established for the DOACs. And so some sources of information that you can use to help your providers with interpretation are information from the main clinical trials, so the Aristotle and the Amplify trials. There is some information in the prescribing information, especially in the information outside of the US. And then there is starting to be some literature available that is looking to characterize concentrations of these DOACs in populations that either have thrombosis or don't. So for example, here is one, the mean trough concentration for apixaban in patients who had thrombosis versus those who didn't. And this is maybe a little bit lower, but this was an N of 2. And so there just are not robust studies in the scientific literature yet to support knowing what concentration will prevent thrombosis, for example. So how do we deal with this in our laboratory? So we actually, whenever we report an apixaban or rivaroxaban anti-10A result, we do not give a reference interval. So nothing will flag as abnormal high or abnormal low. But we do have a long interpretive comment that explains both the assay limitations, meaning if there's also heparin in the sample, this result will also reflect that and will be higher than you might expect. And then also that there's lack of therapeutic ranges. And we do give some guidance with the concentrations observed in the Aristotle trial, but these are not therapeutic ranges. They're more on therapy ranges. What was observed in patients who are receiving this dosing regimen. So back to our cases. So this case was the woman who had the intracranial hematoma on rivaroxaban. Is this patient currently anticoagulated? Can she proceed to surgery? And so the PT and PTT reagents are more sensitive to rivaroxaban than apixaban. So it could be responsible for the prolonged PTT, but it might not be. We just don't know. A more specific measurement, assuming this patient is not on heparin, would be to get an anti-10A measurement. But again, how to interpret that without therapeutic ranges can be really difficult. The other case, this was the case of a patient who had multiple thromboses despite being on apixaban for 5 years, and the providers worried that the patient might not be taking their medication. So is the patient adhering to his apixaban therapy? So again, typically the PT and the PTT are not typically prolonged by apixaban. So the fact that these are normal does not necessarily mean that the patient is not taking his apixaban. You could advise getting an apixaban calibrated anti-10A assay. And if there was a detectable concentration on that assay, then you know that the patient is at least taking some of the therapy, but we wouldn't know if he's taking it twice a day as he should be, because we don't have a expected or therapeutic range for that. So again, difficult to interpret without a therapeutic range is established. So unless there's a clear knowledge of how the result is going to impact care, I would advise not measuring these medications. But that being said, in my laboratory, we have had apixaban or rivaroxaban calibrated anti-10A assays available for clinical use for almost 5 years now. And the first couple of years of the data that I'm showing here are from the first couple of years of having these assays available. So as one would expect, due to the popularity of apixaban over rivaroxaban, this is the most common DOAC order that we have requests for testing for. And then about 80% and 70% of cases, we have detectable or quantifiable DOAC present. Predominantly, is not surprising, again, given that the request for having this test available came from our emergency department. About 2/3 of testing is requested from the ED. The remaining third is requested from other inpatient areas, and then just a few samples are requested from the outpatient side. So from the emergency department, common clinical scenarios that would prompt this include intracranial hemorrhage, life-threatening bleed, or an emergent procedure in someone who is known to be taking either apixaban or rivaroxaban. And then how these values or these measurements fit into our institutional protocol for reversal of these oral anticoagulants is that if the timing of the last dose cannot be determined, that's when reversal would be considered. And then typically if the concentration is above 75 nanograms per mil, that's when the andexanet alpha or andexa reversal agent would be given. If it's lower than that, then it would be a different product, like an activated prothrombin complex concentrate, for example. So we were very worried about how quickly we'd be able to get results out to our providers, knowing the urgency with which they have to make their reversal decisions. And so in the first couple of years, we carefully monitored and tried to improve our turnaround time. And so our median turnaround time from collection to result was 47 minutes. So in-lab time is also quite good at 37 minutes. We were able to report 80% of results within 1 hour of specimen receipt in the lab, and 97% of results reported within 2 hours of specimen receipt in the lab. And so we were pretty happy with this, although I don't think it could ever be fast enough for some clinical situations. So we're always working on ways to improve this. And then some challenges that we've seen is that coagulation testing names can be quite complicated. So anything that involves factor 10, there's a propensity to confuse it. And so in about 5% of our apixaban or rivaroxaban orders, that was the order that was intended, but something else was ordered instead. So like a clot-based factor 10 or a chromogenic factor 10. And so for this, that they will not be getting the test that they need, and they will also not be getting it quickly. So that's definitely a concern. And then there's also a misunderstanding of test specificity. So on the same sample, a heparin anti-10A, enoxaparin anti-10A, or maybe both apixaban and rivaroxaban are both ordered, like multiple things ordered that our assays cannot differentiate from each other. So this happens like 5 to 10% of the time. So what we've done to try to help that is we have order prompts at the point of which our assays are collected, actually at the point of which they're ordered, basically making the providers acknowledge that the specificity, issues, and that you should not use this unless this is the only medication that should be present in the patient. So my recommendations for measuring DOACs, the first one is you cannot rely on the PT and the PTT as global tests of anticoagulation. The most common DOAC that is prescribed these days is apixaban, and most PT and PTT reagents are not at all sensitive to apixaban. So that is really important to understand and to relay to your providers. If you have been asked to develop or provide or have assays available for DOAC measurement, I encourage you to really make sure you understand the clinical need for this prior to embarking on assay validation, because most of the time this is going to be a laboratory developed test, which is really resource intensive for the laboratory. And so understanding exactly, how the providers plan to use the results and how quickly they need the results really will help you gauge what you could do that might be feasible and fit in with what the providers need. So for us, that was really a good collaboration with our emergency department pharmacists, because they were the ones who were most likely to be requesting these measurements and knowing how to use them. I think you need to be cognizant about test naming to avoid confusion with other similarly named coagulation tests. So for example, clot-based factor 10, try to make it so that whatever you think providers will be looking for in your electronic medical record in terms of try finding the test name, make sure that that's a synonym for how you've built your test in your laboratory information system, so that you help guide them to the right test as often as possible. It's important to educate our providers on limitations of the tests, meaning it might be difficult to interpret a measurement once we're able to get one for you. And if you have both DOACs and something like heparin present, that our assays, the most rapidly and widely available assays, are not going to be able to differentiate those different anticoagulants. And then finally, it's always important to monitor important assay performance metrics after implementing your assay. So for us, for example, we were live for a few months before realizing that our turnaround time was actually not good enough, and we needed to make some changes as to how we had the assays available on our instruments in order for the assay to be useful. So finally, take-home points. DOACs are increasingly prescribed for preventing clots and strokes in various patient populations, including both adults and pediatrics. DOACs have the potential to interfere with many coagulation tests, but they don't always interfere with coagulation assays. So, for example, apixaban generally does not affect the most common coagulation tests like the PT and the PTT. So laboratories can really get involved by educating providers, testing for presence of DOACs in scenarios where it really matters, like for lupus anticoagulant testing, and then making sure you mention potential interferences in your interpretive comments. And then it is possible to measure direct factor 10A inhibitor concentrations by drug-calibrated chromogenic anti-10A assays. But the validation process is resource intensive, and we still don't have clear guidance on how to necessarily interpret results because of the lack of established therapeutic ranges. With that, I will thank Stago again for the opportunity to present, and thank you all for attending.
Okay, great. Thank you so much, Dr. Merrill. Just a couple of questions that arose when I was watching your webinar. You mentioned the DOAC neutralizing agent that could be used to reduce or remove the DOAC interference in some of the special coag assays or with the NT10A assay. So what kind of validation would the lab need to do in order to use that neutralizing agent?
Yeah, this is a great question, and one I've been in my own laboratory. I've been kind of resistant to the use of DOAC neutralization agents because it essentially it's a modification to your assays, and so it will essentially become a laboratory developed test. So meaning that you are now responsible for making sure that the use of that product has not changed, the precision or the accuracy of the test. Meaning, so for example, where we're considering using it is for lupus anticoagulant testing.
Mm-hmm.
And so we want to make sure that the removal of DOACs, can we still reliably detect lupus anticoagulants? Does it change our ability to detect those? Does it change, the stability of a lupus anticoagulant in a sample? Because we don't run these, we batch these samples and they might be, sitting in the freezer for a couple of days. So does the use of the neutralization agent change any of that? And so you basically would need to go through and reestablish or revalidate any performance metric of the test, after using this product. So again, I think a lot of it is left up to the discretion of the medical director. But in my laboratory, we would do we would essentially revalidate the entire reagent after the use of those neutralization products, with probably some additional studies related to stability and some other things.
So it could be some amount of work to do that then.
Yeah, I think so, but I think it also, in the context of lupus anticoagulant testing, it probably has the strongest argument of being clinically very important to know if a lupus anticoagulant is present because it could change how the patient is anticoagulated, potentially for their lifetime.
Okay, that's important. And then you should also show that significant levels of apixaban could still produce a normal APTT result. And I guess that confounds the issue of somebody presenting on one of those direct anti-10A inhibitors. I mean, do you find this is a common issue with patients presenting on one of these inhibitors?
Yeah, I mean, I think it's hard because I wouldn't say not all of our patients who come to the emergency department on
Mhm.
apixaban or rivaroxaban necessarily gets a assay sent to the lab. So it's hard for us to know exactly how many. But these oral anticoagulants are extremely common. And
Mhm.
so I can't tell you exactly how many times. I think it
Sure.
happens more often than what we see testing for, is what I'm trying to say.
Okay. Because it seems like the doctors may need to bridge these patients to heparin, or that seems to also be a controversial practice in itself too.
Yeah, I think it's really variable depending on, like what the patient, how long they think the patient, if the patient needs to be admitted, how long they'll need to be admitted for, and like what procedures they might need to have, and of thrombosis. I think that all kind of goes into that calculus. For us at our institution, so we still do heparin monitoring via PTT. And so actually I wouldn't say immune from a lot of this, but we're less, and our PTT reading, especially to apixaban, is not that affected by it. And so in some ways, that helps a little bit because they can use their PTT based nomograms, especially in the presence of apixaban, and not really be worried about apixaban kind of interfering with that.
Sure.
Um,
Okay, great. Well, thank you very much. That was a really interesting webinar, and we appreciate your help to educate our audience.
Great. Thank you so much.
Okay.